Okay, thank you everyone for joining us today for a discussion with Lisa Apperson and Tricia Sinek to hear an executive and operational view on how critical access hospitals in rural Washington and Kansas set up dialysis service lines, enabling them to better serve the needs of critical patients in their communities. Reminder that you can pop in questions throughout today's webinar using the Q&A icon located on your Zoom controls, and we'll have a live Q&A at the end of the session. And with that out of the way, I would like to turn things over to Dr. Silva. Dr. Silva?
Thank you. Good morning, good afternoon, everyone. I'm so happy that you're here to join us. We are going to be talking about some of the challenges and, more importantly, successes that these two professionals in healthcare have had with critical access hospitals and caring for patients in rural communities. There's going to be time at the end for Q&A. Please type things in the chat at any point in time. And first, I'd like to introduce and start with Tricia Sinek, Strategic Coordinator, joining us here from Washington. How are you, Tricia?
Good, I'm great. Happy to be here this morning or this
Fantastic.
afternoon.
I know, right. I don't know what time zone everybody's in. So, you're at Kittitas Valley Health, correct?
Correct. Kittitas Valley Healthcare. And
Why don't you tell us a little bit about it and kind of set the strategic challenges you were experiencing before you introduced dialysis, because you didn't have it before you went live with your program.
So I've been at Kittitas Valley Healthcare for about 4 years. And when I arrived there, one of the big concerns that our chief medical officer and our senior leadership had was that we were transferring patients out for dialysis. And of course, this was a problem before the pandemic. And as the pandemic developed, it became a bigger problem because the nearest hospital to us was 40 miles away over some pretty treacherous roads in the winter. And that particular hospital where we sent a lot of patients that potentially needed dialysis in the past happened to close half their beds during COVID because they didn't have the staff to take care of patients. And so all around the state of Washington, we experienced this problem. And so we didn't really have a place close by to transfer our patients who presented to the ED and needed dialysis. So we actually, before we started down the road of really looking at how we could do it ourselves, we tried to partner with other organizations. We tried to partner with DaVita. And of course, they had their own bandwidth issues during the pandemic too. So that didn't work despite repeated efforts. And then we reached out to Northwest Kidney Centers, which is quite an established provider of dialysis services in the Puget Sound area, which is on the other side of the mountains from Kittitas Valley Healthcare. Kittitas is located predominantly in Ellensburg, Washington, which is right smack dab in the middle of the state along I-90, which is a major highway that crosses the United States, and about 100 miles from Seattle over a pretty treacherous mountain pass again. So they decided that they weren't really set up to provide telenephrology services or teledialysis services. And they also weren't set up at that time to really train nurses how to become dialysis nurses. So after trying to pursue those solutions for a couple years, we decided we needed to find another solution. And one of the drivers for this was, as I said, we were transferring patients out. And during the pandemic, it was horrible. And I looked this up this morning in preparation for this. I thought the farthest we transferred a patient was 500 miles. But we actually had to transfer a patient for dialysis from Ellensburg to Idaho Falls, which is 664 miles away. So you can imagine that poor patient and their family, when they were out of the hospital, when they were discharged, they have to find their way back to Ellensburg, which is quite burdensome for patients. And a lot of these patients are pretty frail and may not have resources, they and their families, to arrange that. So we were really looking at the burden that not having this service was for these vulnerable patients in our community. And the county has a population of 50,000 people, and there's only 19 people on dialysis at the DaVita outpatient center there, but there are many people on home dialysis. And also patients were leaving the area and going to Yakima and other places for dialysis. So we figured there was pretty significant demand. And in 2022, really the last year that we kind of built our pro forma on, we transferred 22 dialysis patients out of the emergency room. As soon as they arrived, we recognized they needed dialysis. We needed to find a place to transfer them. And then 13 additional patients were transferred out of an inpatient bed to another facility because it was determined during their inpatient admission that they might need dialysis. So we knew this was a significant need in our community, and it was something we felt we could do. So what we did is we set out to look for partners that could help us build an inpatient nephrology program in a critical access hospital. And we encountered Outset, which was really exciting. And they had a great team. Amber was the person who first connected with us. And we learned all about their technology. We pulled a group of stakeholders together, and we felt that this was something that was doable for us. And so we proceeded to work with Outset to purchase our dialysis machines, and then to start on the project development work to find telenephrology partners for us, which was a great experience for us too. And also to have a project manager at Outset to help us walk through the whole process so that we were ready to go on our target start date. And that included sending some of our nurses to a training in California at a special dialysis training school. So we opened up these positions to all of our nurses, and we had 2 nurses right away that wanted to go to the training. And we have a 3rd now that's getting ready to go to training. And we partnered with 2 nephrologists, and they have a business called Insat Health. And they support us 24 hours a day, 7 days a week, 365 days a year. And they're available to do consults for patients that may have kidney concerns during their inpatient admission. And they can consult with the ED and our hospitalists. And they manage all the dialysis care for these patients while they're in the hospital. And this has turned out to be a really good model for us. And we'll talk in more detail about what that looks like for us.
So Trisha, I don't want to interrupt you, but just, it rolls off your tongue so easily, you make it sound really simple. But I think a lot of people, they struggle with aligning their organization around the problem, right? So as a nephrologist, I think there's a problem. It doesn't mean that my, CNO agrees with me, or my CNO feels there's a clinical or a safety need. Of the things you just discussed, can you just point out to everybody who's joined how you align the organization around the problem so that it was seen as everybody's problem and then everybody's win once it was solved?
I think we already had a core alignment with our senior leadership group, especially our chief medical officer, who'd been trying to address this issue for many years before I came aboard, and who really hadn't found a solution at that time. And then I think the pandemic really confirmed that this was something we needed to do, because there were no dialysis beds anywhere around us at the usual places that we would transfer patients to. So we realized if we wanted to take care of our community that we needed to do this. The second thing is this became part of an overall project to look at how do we say yes to more patients and how do we transfer fewer patients. And so one of the ways that we did that is we engaged with a new hospitalist group that had more sophistication and training and more comfort taking higher acuity patients. So we knew that they were prepared to help take care of these patients, and they were more comfortable saying yes. And also we had a change in our emergency room leadership. Before this, we didn't have fellowship trained ED docs, and now we do. And so what we're looking to do overall is to elevate the types of patients that we can take and safely care for in a rural setting. And if you have all these tele-experts, that now are easily and readily accessible, and then you have providers on the ground who are willing to try this and to work with us to make sure that we can do this safely and do it well. So we already kind of had alignment in our organization. I think it would be harder to make the case if you didn't have that internal alignment, although I think we're seeing across the country a pullback in dialysis access, especially in rural communities. So this is really an important thing if you want to keep those patients in your community. And we serve a particularly older population. We have the second oldest population in the state of Washington, and we are geographically isolated. So every barrier that a patient or their family has to overcome, whether it be distance, the cost of traveling, being with someone, a family member who's far away in an inpatient bed, all of those are barriers and challenges for the people that we serve, and we are really trying to be able to serve the patients that we can safely in that rural setting. And so we felt between Outset and the telenephrologists that we work with, that we could do this safely and we could do it well. And so that's really what drove our decision. And there wasn't a lot of conflict about this decision internally, which may be different than other organizations.
Right. Well, and I think to your point, you alluded to, we're going to discuss the financials. I think also, and we can turn to that now, looking through the financials, the projections, that really supported the buy-in. And that's another piece that can help persuade the organization in a positive way. Why don't you tell us what we're looking at here?
Yeah, so part of my role is to look at clinical programs and then to build financial performance. So we have some idea of what the return will be for these programs. And if there won't be a return, we know what we're getting into before we start. And so, as I said, this is a first look at what the startup costs were for us. And some of this is different than we originally projected, and I'll go through that. So we signed a contract with INSAT, these telenephrologists, and their medical directorship and their oversight of the program. And they helped us develop all our dialysis policies and procedures. They worked with our IT team to build order sets and to build lab orders on all of those pieces. And they cost us $35,000 a year for that. Our RN training was a pretty big expense, although it wasn't that much because we've only sent 2 RNs to date. But they have to travel to LA and they're there for 7 days. And so you need their tuition and all their travel expenses to do that. Our dialysis equipment, although Tableau recommends you buy 3 Tableau machines, we felt we could try with 2 first and see how that worked. And so far that's working for us. So our dialysis equipment was 2/3 of that number that you see there. It was about $110,000, I believe. And then the biomed service fee for taking care of those machines is also a little less than we originally projected. Our dialysis supplies, that we are not actually spending that much, which we were surprised by, but we didn't really understand those dialysis supply costs when we originally started down this path. So when you look at this original pro forma, I have a tendency to overestimate how much things will cost because it's always better to overestimate than to underestimate and be surprised. It's always better to spend less and have that be a pleasant finding rather than finding out you're in the hole more than you thought. And as part of our contract with our nephrologists, they charge us $395 for each new consult, each new dialysis consult. And we, of course, can bill for that because they are credentialed and privileged with us. And then there's a charge for progress and follow-up notes. And they charge us $55 a day for 24/7 on-call coverage, which we think is very reasonable. And I'll talk a little bit more about them in a minute, but and then the medical director dialysis session fee, that's to support our RNs and our staff whenever we start a dialysis session. if there's any needs that we have. And of course, that's winding down as we become more familiar with doing dialysis. And then each dialysis RN stipend, we are paying our nurses $350 per dialysis session, plus whatever they make working their shift. And the reason we do that is it follows our contractual arrangements for other specialty services that we provide. And what we did is match the current program that we use for our sexual assault nurses. So we have 4 nurses that are trained in performing sexual assault exams and collecting that forensic evidence. And they get paid this $350 stipend when they get called in to do this. And we figured this was very similar to that. So that's how we chose to compensate them, because basically our 2 nurses that are doing dialysis right now and our 3rd that's going through training now, they're on call. So they're on our call schedule. And if there's a need for a dialysis run on that day, they are called in. So they're paid the hours they work plus this additional stipend. And then any miscellaneous costs not factored in. And then our bed reimbursement, because we're a critical access hospital and we are doing dialysis in our critical care unit, we felt that was the best place to do it. And we had to do quite a bit of plumbing work and that kind of thing for 2 rooms in our critical care unit. And we are compensated about $5,000 a day for the room charge for those rooms. And then we felt we would receive between $1,200 and $1,500 per session for the additional charges for dialysis. And we turned out to be quite wrong about that. We are charging.
Let's show, yeah, let's show on the animation so everybody can see while you talk through how favorable it was in real life.
Yes. So again, most of what you see is there. So we penciled out, we predicted that we'd have about 25 dialysis sessions in year 1 with an average 2-day length of stay. And we dramatically underestimated that demand. And I'll talk about that in a minute. So we looked at what our year 1 costs would be in addition to our startup costs. And you can see that our total revenue in year 1 was predicted to be 280 to 287,000 plus, and then so that would be close to breaking even when you look at our startup costs and our year 1 costs. And then we predicted that in year 2, as the program got underway and the local dialysis patients and physicians and everybody realized that we were able to do this. And we also can keep patients who have acute kidney injury, which in the past we transferred all those patients out of the ED immediately. And now we can admit those patients and take care of them. And if they need new dialysis, we can put in a line and we can give dialysis. So in year 2, we predicted that our annual costs would run around $173,000, but our revenue would run $784 to $805, giving us a return on this investment of more than $500,000 a year. So this is how we predicted, and really a very simple pro forma looking at the cost of providing this care to patients.
Yeah, so what you're saying is you service more patients up front more quickly than you had anticipated, and reimbursement was a bit different in terms of favorability.
Yes, much better than we anticipated. And what's not included in here is any surgical fees for line placement. So we've already had significant experience with that too. I just didn't put that in the pro forma because frankly, I didn't anticipate that that would have an impact on us, but it has, and a favorable impact.
Thanks, Tricia. This is really helpful. I think we're going to switch kind of to a bit more of a tactical view with Lisa, and then come back in the end and talk about a little bit more, future looking. So Lisa, thank you for joining us. We're happy that you were able to be here today. We know that you've set up multiple outpatient dialysis clinics throughout Kansas and have a lot of real world experience. many people feel overwhelmed by this in healthcare. So we'd like to start with, staffing and some of the choices that you made to enable your success. Specifically, what did you learn, let's say the hard way about staffing?
Well, since you're looking at a rural facility and critical access hospitals, you're looking at a very limited pool to pull nurses from. And I found that to be a challenge. Like, some of them wanted to do it, but some of them didn't even want to walk in the room. They were so scared of the machines. So I was able to pull in some nurses, but when I did this last program, I'm trying to hire nurses and they're saying, no, 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 we can't have any more nurses. So they're looking at the cost versus the benefit ratio, which I'm looking at the patient side and they're looking at the cost side. So it was a little difficult to feel like I fully staffed and had a safe number of staff in there for the patients at any given time. And I left thinking maybe they'll do it at some point, but they're just scared. And another thing that we had problems with that kind of fed into that is, as you know, about the IV fluid shortage because of the hurricane. So they don't even let us add any patients or even think about adding a nurse until all of that is settled. But I urge you to, if you're in this position that I'm in, keep rooting for that extra nurse in there for your patients, because that is the safest thing. Sure, one nurse can run two patients, but somebody pulls a needle out, somebody's hypotensive. You really do need that extra set of hands. And we have pushed and pushed for that. Like I said, it didn't really work out, but that's what I ask you to look for first going in. Can you get the staff that you're going to need to run these patients every single day? And can you have them off orientation in time to start at your goal date? Because that is another issue as well. We pulled a nurse who's only doing it part-time or PRN, and she's been at it since May and she's still not off orientation because she just hasn't been over there enough. So all those things factor into that safe patient ratio for these dialysis nurses, especially if they're in a kind of isolated area of your facility where they can't really call for help quickly. And then the other thing is, sometimes as you are a dialysis nurse, yes, a body can come help you, but sometimes you just need somebody to already know what they're doing. You need that dialysis education and knowledge, because I sometimes don't have time to give instructions because I'm in a critical, incident. So that's what I urge you on staffing, is start with that. And if your CEO doesn't think you can do that in any way, shape, or form, then you need to look at that realistically before you move on.
So yeah, I think we've all had these challenges with dialysis programs. That being said, you've used different machines and you've been very vocal about being a champion for Tableau.
Absolutely.
So how is it different with Tableau, given these challenges frequently actually seem daunting at times?
Yes, I worked at a large level 1 trauma center for 6 years doing inpatient dialysis. And we had the Gambros, which are good machines. I don't have any problem with them, but they're much larger and harder to handle. Portable wise, you're also pushing an RO and a water softener on that machine. So it's about an 800-pound cart you're pushing around the hospital, versus a Tableau that can do it all without any extra equipment. I do like the Tableau because it's also very user friendly. And I've had, some of the nurses say, I don't want to touch it. And I'm like, you can't break it. You literally just do what it says on the machine. You can't hurt the patient if you're following all the instructions. So I feel like they gather that information and feel comfortable with the machine quicker than they do on some other machines that are harder to set up. So I am a huge champion of Tableau. I believe that it should be the only machine people are using, because there's no way that a critical access hospital or anything like that could ever do a regular dialysis program. The water room itself is restrictive to that program. There's no way they could afford that. And also they maybe don't have the actual physical space for it. And that's kind of what I ran into in my last one. We're already really have enough patients that we could open another room, but they won't let me take another room from their census. So they're looking at maybe having to build on. So do you have the physical space it requires to have your patients, and what you think you're going to be able to run is another big will. So tableaus don't take up as much room. I technically probably could have put 3 tableaus in that room and 3 patients, but I didn't feel comfortable enough to do that. I felt like the patients would have been too close together. So we didn't, but the fact that you can just, take it and roll it down the hall and hook it to a faucet if you have to is amazing. And then I tell people these are the same machines these patients use at home. If they can do it, you can do it. Don't worry. So I do love them, and I'm very glad to be a part of this program.
Thanks, Lisa. I think, for many of us, I used the machine before I joined the company. I have the same sentiments that you've just expressed, but what were some of the hesitations or initial reactions that the nurses had before they began using Tableau, and what did you see play out from there, just so that people can know what to expect? Or, obviously nothing is without a learning curve.
Right. I just had to remind them, pay attention to your screen, that because they were thinking they were going to have to go in there and just do it from memory or do it from a book. And I, after they got their hands on it, and I felt the same way when I started, after I got my hands on the machine and actually did a full setup, it made so much more sense. And I feel like that my nurses did the same thing, and but I feel they acclimated to it quickly. I think much quicker than the other machines I've worked with, just because they're so user friendly and they are literally step by step. You can't do the next step unless you hit that button. So I feel like my nurses in this last program caught on pretty quick. And I actually do have a PRN nurse there that works at one of the larger facilities with a different machine. And I'm not worried about his dialysis skills, but he had to learn the Tableau, and he feels like it's much, much simpler, much user friendly than the machines he uses at the other facility as well.
Did you see a difference in nurses who differ in their tenure or their skill set that you could share with everybody?
Well, I had an odd mix, I'll tell you. So one of my facilities, I had a nurse that's only been a nurse for 2 years, but she'd worked in the ICU briefly. They tagged her to be my replacement because I was just an interim. And then my other nurse I had there actually had more experience in dialysis than I did. She had ran her father at home for 12 years on dialysis. So when we got to the fistula exercise, I'm like, you have more experience on fistulas than I do. Why don't you teach me? And she's like, oh, it's been a few years. So she was a little hesitant because the machine was different. But she turned out to be a great employee and doing dialysis very well. And she'd been a nurse for like 30 years. So I had this brand new nurse, and then I had a very tenured nurse. And both of them seemed to adapt pretty quickly. In this last facility I did, both of my nurses I pulled were ER nurses. So I think it was a little difficult for them to take that lack of adrenaline and slow down and just let the machine tell them what to do. I think that was a little difficult. And my manager that I trained and left, who is going to rock the program with, no doubt, but I could see in her face when we were just running the one patient for free every day because we're charged till we got accredited. And she was just sitting in there watching the patient, and I saw the look on her face like, I don't know if I can do it. And I said, please hang in there. It gets better when you have more than one patient. And of course, you've had issues either with the machine or the patient. And she reacts very quickly to those because of her ER background. And I think she's gotten a lot better with that now, where she doesn't feel like she's bored. But that was a little different for them to slow down from their usual workflow.
Yeah. Yeah. And that they have more time with the patient. I think that's something
Yes.
people end up learning and forget that they've moved towards managing a device than managing their patient. So.
And Cynthia, I'm not sure this is the time to share this, but it came in my brain, so I'm going to share it. speaking of learning your patients and getting to spend time with your patients, we had a patient, he was our first patient. He's been blind longer than he's been on dialysis. So he has no, visual cues at all when he's in dialysis. He hated it. He'd been driving an hour, well, not driving, but riding a bus an hour. Hated it, hated it, hated it, hated everyone up there, and would tell you that without you even asking. And a few weeks ago, our social worker was looking through paperwork and realized that he'd had a DNR at the other facility. And we've worked very, very hard to build a relationship with this patient. And I think my manager, I think her and him have a very close relationship, because she's the one that stuck him every day. And he'll chat with us, and, he'll talk. And the other facility was like, oh, he's really hard to deal with, and da da da. Well, our social worker asked him about the DNR because we didn't have that in our paperwork for us. And he said, his response was, well, when I was going up there, I didn't want anything done. But now that I'm going here, I want everything done.
Yeah.
And to me, that is the biggest compliment somebody can give anybody, especially coming from him. We literally gave him his will to live back.
Yeah.
And I don't know how much better it gets in nursing. That is just a huge, compliment to me, to the program, and knowing that we'd had to work so hard to do that.
Yeah.
And it was good. So that is my success story that I'm going to share forever and ever and ever, because
That's
it's so good.
fantastic.
And if you knew the patient, you would feel just as I do, because it was a very much 180-degree turn. So we're very glad to be part of it. And we have 3 men that were dialyzed in that program. We call them our boys, and we love all of them. We're very attached to them, and they're very spoiled.
Yeah. I mean,
So-
I would tell people, and this kind of fits squarely into what you said, patients aren't giving us a hard time, they're having a hard time.
Yes.
And I think
Yes.
it's easy to forget that, but when you have excellent resources, technology, and staff, the level of care you can deliver can yield something that is so memorable and impactful, like you shared.
Right.
So
And he shared with us that they would literally come up and grab his arm and stick his fistula without even saying his name.
yeah.
And so those kind of things we have to remember. We have to go back to our nursing basics. These are patients. They're not just a piece of meat sitting in that chair that we're running a machine on. And
Right.
I think that is a huge, huge thing for our program. It speaks highly of what we did out there.
Yeah, I would agree. Thank you. Thank you for
Mhm.
sharing, Lisa. I want to switch gears a little bit, kind of forward look with both of you. So, Trisha, I'd like you to give the audience some insight into how things are playing out now at Kittitas, and what would you report kind of your future looking vision for your program, given, where you are, and, remind them just how young you are in this program.
Yeah, so we actually we gave our first dialysis treatment at the end of July this year. And, it was a little bit of a bumpy ride, the first patient, that's usually the way it works, and we had alarms going off on the machine, and our nurse, got a little rattled, but we got through it. And now they've been doing it for 4 months, and they, feel comfortable. They feel good about it. They understand how the machine works. And patients are so very appreciative not to be shipped out of the community for this. What we're surprised by is the demand. So in the first 3 months, we dialysized 7 patients, and we kept other acute kidney injury patients that we were able to take care of because we had a nephrologist directing the care. But we performed dialysis on 7 patients for a total of 17 dialysis runs. So if you remember that pro forma, we thought we would do 25 runs the entire first year. And we're going to be there in half the year. We're going to exceed that. We're actually probably going to end up the year close to the end of our year 2 projections. So there is demand that we weren't anticipating.
And not to interrupt, that kind of happened to us as well. truly became a build it and they will come.
Yes, exactly. They're kind of like a hidden population and you don't know about them. And we also didn't know if some of our EMS people were bypassing us because they knew that
Right.
we didn't have dialysis.
Mhm.
So there's actually quite a few more patients in the community that have dialysis needs or advanced kidney disease that we can take care of now that we didn't anticipate. I think the other thing, and I didn't say this, is that the Tableau machine is amazing. It's not as scary. It's it doesn't sound nice to say this, but I call it dialysis for dummies, just from the standpoint that it walks you through the whole process. So you don't have to be an expert and you don't have to be a mechanic. And it's easy to operate. And
Right.
what we did when we were considering this is we actually had out said, bring a Tableau machine, and we did an open house and we invited all of our staff to come look at the machine and see how it operates and, so that they would understand it's not this big scary technology. And that made a big difference. And then of course we got nurses that signed up to participate. The other thing we did, we have two nurses that are pretty experienced. One of them, one of our main, he's our coordinator for dialysis now. He's an older ICU nurse and he worked nights for 20 some years and he was getting ready to retire or to cut back. And we said, we have this opportunity and it's during the day and it's limited hours. Would you be interested? So he was a highly skilled nurse that kind of leads this program. And it's good for him because he's not abruptly, retiring, and he
Right.
can mentor and guide the program for the next couple of years. So that's worked out to be a really good strategy. I think, so some of the fear nurses had about, we're a critical access hospital, we shouldn't be doing this here. I think those fears have been put to rest. And that's
Great.
been great for everyone to see. And the nephrologists that we partner with have been just wonderful communicators with our nursing staff. So our nurses feel comfortable calling them and asking them questions and talking to them whenever they need to. So having that kind of support has been invaluable, and that the support from outset has been invaluable. I don't think we could have chosen better partners all the way around. So that's been really
Thank
nice.
you, Trisha. That's a
Yeah.
great.
And I think the other thing is we're getting feedback from patients. They're just so appreciative
Right.
to be able to stay in their home community if they get sick and need to come to the hospital. So all
Yeah.
around, it's been a win-win-win. It's a win for our patients. It's a win for our team in learning to take care of more acutely ill patients. And it's a win from a financial sustainability perspective.
Yeah, thank you. So Lisa, just before we open up to questions, given your expertise based on what Trisha said, what are one or two things that people really need to understand the patient in a rural setting who needs dialysis and how they differ?
Well, sometimes, of course, transportation is an issue. And so that hour away literally gives them part of their life back where they don't have to do that anymore. So we have two patients that can drive themselves. One has to ride the bus. So there's some problems there because the bus doesn't run every day. So we're small enough that we were able to go get our patient in the company car and bring him. So we've been able to deliver that service to him. But I think mostly it's just that time we give them back. It's immeasurable how much better they feel. And I will tell you that my two patients were on, other machines prior, and now they tell me they feel so much better at the end of their treatment. They don't feel so wiped out. They feel like they can go do things. And I really see that in their faces and their actions as well.
That's great. All right, we have a bunch of questions coming in. So if you both don't mind, the first question I have is, what is the bed size of Kittitas? And what about smaller hospitals without a CCU? Are bedside nurses running the dialysis?
Yes, I think that was just a decision we made to have it done in the CCU. But you don't need to do that. It can be done in any hospital room. And we're a critical access hospital, so by definition, we are limited to 25 beds. That's our total number of beds, but we have 16 separate clinics in our system. But in terms of inpatient beds, only 25. 6 of those are dedicated for family birthplace, 6 are CCU, and the remainder are med-surg. So we can't have any more beds than that, or we lose our critical access hospital designation, and that has financial implications for a rural health system because you are reimbursed for your costs in a rural health system, a critical access hospital, which is different than a non-critical access hospital reimbursement.
And I will say, Trisha, speaking to the inpatient as well, but the first program I did both, but we never actually dialyzed an inpatient. This last one I did is strictly outpatient, so there's no inpatient involvement at all. If they were to get sick, we would ship them to the next bigger hospital, which is an hour away. So we had limited resources for that. They decided not to do inpatient, although, as you said, Trisha, I would have loved to do that. I think our nurses could have handled it, but they just chose to only do outpatient.
Yeah, I think the fear of doing dialysis is much greater than the reality. And it really hasn't been that big a hurdle once they got over their initial apprehension and did some, took care of some patients. That apprehension is gone now.
Yeah. Without getting off into the weeds, I'll just say our biggest problem in both programs has been the billing. So that has nothing to do with the machine. It's just the billing. And so I think that's been the biggest hurdle.
Well, yeah, and I think understanding the billing in general is one of the biggest needs in healthcare right now. So I completely agree with you. Just to tack on there, we have a bunch of questions coming in. Did either of you do a swing bed or LTC patient? They have a hospital with a swing bed and an attached 60-bed LTAC.
We found out that with the billing, you cannot do a swing bed patient because that money comes out of the swing bed reimbursement. So we chose not to do that. We don't have a LTC side, but we did have the swing bed, and that was a question right off the bat. It would be double billing because I didn't understand why, if they could take them to a dialysis facility 2 miles away, we couldn't just roll them down the hall to our facility, especially if they were already one of our patients. And they said, nope, because that would be double billing, which would be Medicare fraud. So that was a big no.
Yeah, and we have a swing bed program, but we don't put these patients in that program.
Yeah.
We don't designate them as such.
How should a hospital determine the local need for dialysis? So they're kind of getting at how, for example, numbers, data to suggest adding this as an added outpatient service. What did you guys use to determine that?
Well, Outset helped us with some data. I don't know about you, Trisha, but they were able to pull data from, I'm not sure, I think probably billing charges and such for AKI and that sort of stuff. But they were able to give us a rough number. And I'll say we've lost a couple of patients who've decided to go hospice, but we've replaced them twice. So if originally we had like 8 patients, and then we were down to 5, and now we're back to 8. Because they literally just keep coming, or they find out about us and know they've been driving an hour, and they're just so excited that we're closer.
I think for us, several things. Outset had data for us. We have an internal data person, so I had her pull diagnostic codes from all of our clinics and that kind of thing, so you can get pretty good data that way. Our state Department of Health also has data on end-stage renal disease for all the counties. And so we looked at all that data, and then we worked with our nephrologists, and they said the formula they use to look at demand is for every dialysis patient in the community that you're serving or you're wanting to serve, you can count on 1.6 inpatient admissions per year. And so when I did that pro forma, I counted that they might just have 1, maybe 2 dialysis runs a year per patient. But what's actually happened is, one of those 7 patients in the 17 runs we've already done was a patient that was in the hospital long enough to have 3 dialysis runs. So actually, these patients are ending up, almost all of them have at least 2 runs while they're admitted to the hospital. So that was more than we anticipated.
Yeah.
And I think, I'm not an expert in kidney disease, but I think the incidence is on the rise because of diabetes and obesity and all those things. So it's not like this patient population is going to go away.
No, and again, I'd love to have another webinar to talk about the best way to execute home dialysis, because that could really bring admissions, hospitalizations down, but we don't have time for all that. It looks like we lost Lisa. Maybe she'll jump back on. That's the beauty of a live webinar. But Trisha, I have one last question. So thank you for sharing the financials. What was the payer mix and how did you charge CCU bed for dialysis? If you could give a little insight there.
Yes, our payer mix is pretty good, except keep in mind most dialysis patients are on Medicare, Medicaid. So that's who's reimbursing for you. And as I said, because we're a critical access hospital, we get reimbursed on a cost basis. So what it actually costs us to provide the service, we get reimbursed a percentage of that cost, which is better reimbursement than most facilities get. We get about 60 cents on the dollar for everything we bill. And some systems it's considerably lower than that. And as I said, our typical charge for one of those beds is about 5,000 a night. And then in terms of what we charge for the dialysis, we did a review of all the dialysis inpatient billing rates around us, and some of them were quite low, and the highest one was, I think, about $7,500 a dialysis run. So we try to, when we look at our charges, our typical charges, we try to be kind of midstream. We don't want to be the most expensive and we don't want to be the least expensive. And so we get reimbursed a percentage of those charges, but that was much higher than we thought it would be.
And against the inpatient side, the outpatient side is completely opposite of that. And so I have to remind people that quite often that it is not a money maker when you're doing it outpatient. So we didn't even get designated as a rural facility to have that extra reimbursement, which I thought was odd. And that is an issue. So eventually, for those of you that don't know, all dialysis patients get on Medicare. Eventually, they have 36 months that they can stay on their own program if they have it. But at 36 months, most insurance companies will kick them onto Medicare. So you don't really have a choice in patients that you take, that you say, oh, I'd like to take this patient because they have private insurance. Well, they do, but they won't for long. And so that has to be factored in. And there's just nothing you can do to increase your revenue on that side of it when it's outpatient. It's just so capitated by Medicare.
I think several years ago, I think I read that the annual cost for a dialysis patient exceeds $80,000 a year.
We get we get like 222 a treatment.
Wow.
And we're dropping an $800 charge.
Wow.
Have either of you done a cost report since you started?
We are still working on it because we have yet to get reimbursed by Medicare. Every time they send the bill, it's gotten kicked back. So they're still working on that. So I don't think she could truly do that until she starts getting some reimbursement.
Well, expertise in billing is a must.
Yes.
And we built that with the help of, all of our partners before that. And since we started doing dialysis, we are auditing that coding and billing too, to make sure that we are getting paid for the care.
Trisha, I might have to talk to you on the side.
Okay.
I have another billing question. Are you able to do dialysis on a swing bed? You can't bill as a separate fee?
No, that would be double billing. They told me. I looked into that. So if I had a swing bed patient and say, I have no idea what they reimburse for, but say they get $5,000 a day, whatever we charged in dialysis would have to come out of that same pay. So you would be losing money on your swing bed patients. So our facility chose not to even try.
So basically, we need our next webinar to be all about dialysis billing. So
I would love that.
Note taken. Well, we have about 5 to 8 minutes left to go. I want to end timely. I want to thank you both for joining, for being open, for sharing your experience with everybody, for all the work you put into preparation. I want to thank everybody else for joining and listening in, and most of all, keeping your focus on patient care, because they are the reason why we all put all the time and effort into what we do. So thank you both so much.
Thank you.
Thank you for having me.
Have a great day.
You too.
Thank you
Bye.
Thank
everyone for
you.
joining us today. A recording of this webinar will be available and shared with you all. With that, have a wonderful holiday season.